Hi, I'm Meredith Marr at the University of Maryland Medical Center Midtown Campus. Today we're discussing hepatitis C with Dr. Eleanor Wilson from University of Maryland Center for Infectious Diseases. Thanks for being here today.
Thanks for having me.
And thanks to all of you for watching. We invite you to leave your questions for Dr. Wilson about hepatitis C in the comment section below, and be sure to like our page and video if you haven't already. Dr. Wilson, let's start off talking about what hepatitis C is. Can you explain it to us a little?
Absolutely. So hepatitis C is a virus. The virus infects the cells in the liver and causes inflammation. That inflammation of the liver is called hepatitis. Hepatitis is not the only virus that can do it, but it's one that we've recently learned a lot about and now we're able to treat.
What are some of the symptoms of hepatitis?
The problem is often there aren't symptoms. So it's a virus that causes problems over decades, and usually people initially at the time of infection don't have too many symptoms, don't even know that they've contracted hepatitis C. And then over decades they might develop problems like liver failure, they might develop low blood counts, low platelet counts, problems making clotting factors and other things, and it can over time lead to a risk for liver cancer.
What's typically the first symptom that presents when someone has hepatitis C?
Usually most people actually are sort of picked up by their primary care doctor when they're doing just routine lab work, having inflammation of the liver and abnormalities in the liver function tests. But many people don't even have that. They might not have problems until decades later when they develop jaundice. Yellowing of the skin or the eyes is usually the first symptom.
Can you be born with hepatitis C?
You can. The transmission from maternal to child transmission through birth exposure is less common, but if somebody does have active hepatitis C, about 1 time in 20 they will transmit hepatitis C to the child.
Other than transmission during birth, what are some other ways that people can contract the disease?
Hepatitis C is usually contracted through exposure through infected blood. So often we think about blood transfusions before we learned how to screen the blood supply in 1989 or 1991. So that's sort of one typical exposure. Sometimes we think about injection drug use if you share equipment with someone else. But there are a lot of other ways to get hepatitis C and exposure through blood. People can be exposed through sexual activity. People can be exposed through amateur tattoos where needles haven't been sterilized. They can be exposed by sharing razors or other things that come in contact with blood.
Great. And what's the difference between the different hepatitis? So hepatitis B, A, C, is C the most common, or what's the difference between them?
Infectious disease physicians are not always the most inventive, so we just named hepatitis sort of as they came along alphabetically. So for a long time, hepatitis C, before it was really identified, was just called non-A, non-B hepatitis. All of the viruses affect the liver and can cause liver problems, but they're all very different and they're all contracted in different ways. So hepatitis B is more commonly afflicts people. People are more commonly born with it after contracting it from their mother in utero. Hepatitis A is usually more of a foodborne illness. Hepatitis C, blood, as we discussed. Hepatitis D is kind of a funny virus that needs to be contracted along with hepatitis B. It's sort of a non-functional virus. So they're all a little bit different, but they all cause inflammation of the liver that can then have consequences in terms of liver failure.
If you have hepatitis C, are you more at risk of having another version of hepatitis as well, or is there any comorbidity that typically goes along with hepatitis C?
So the one thing that you're not more likely to contract one of the other ones, but you're more likely to have a problem. So they're kind of more additive. So if you have hepatitis C and then are exposed to hepatitis B, then you're more likely to have inflammation and develop liver cancer because of the sort of combined inflammation from the two different viruses.
Are there any other diagnoses outside of hepatitis that typically goes along with it?
So hepatitis C in general can be associated with other problems, including, problems limited to the liver and then problems outside the liver. So it can also cause problems with kidney function. It can lead to problems with vasculitis. You can sort of have other sequelae outside of the liver that go along with hepatitis C. And then it can make more people sensitive to certain liver toxins. So if you have hepatitis C, then we usually advise people not to drink alcohol because that can result in more damage than just drinking alcohol without hepatitis C.
Other than not drinking alcohol, what are some other things that can help prevent you contracting hepatitis C?
So in order to protect yourself against hepatitis C, we usually encourage people to be careful with to avoid injection drug use or be careful to not use needles with anyone else. We also encourage people to not share razors, to protect themselves, practice safe sex. Those are really the big things that we counsel. In terms of protecting your liver once you have hepatitis C, then it's avoiding excessive amounts of Tylenol, because that can be an insult to the liver, avoiding hepatotoxins like alcohol, and then in general, just the other things you do to be healthy, controlling blood pressure, taking care of your kidneys, drinking plenty of water. All of those things will just help from making it worse. But for the most part, you need to address the virus.
Since hepatitis C is blood-related, is that the only way that you can diagnose the condition?
That's a good question. So, since most people don't have symptoms, they really need to be screened. We need to look for it. And it is a blood test that you need to do. For other viruses, for hepatitis B and for HIV, we can do an oral swab. But hepatitis C, you need to draw blood and be screened. There are guidelines that all baby boomers should be screened for hepatitis C, but we're actually learning now that you do miss a lot of cases when you do that. So really, everybody should be screened at some point, and then if anybody has received a transfusion in the past, or before the blood supply was screened, or knows that they've had exposure to somebody with hepatitis C, it's just worth it getting checked.
So baby boomers, those with IV drug use, those not practicing safe sex, who else might be at risk for hepatitis C?
Those are the big groups. Those are the people that we really recommend doing screening and really discussing with. But many people have had unprotected sex. Many people have shared a razor or something else. So it's really worth getting screened, because it's something that is treatable, and especially at earlier stages. If you're treated at earlier stages, you can prevent a lot of the complications that we worry about.
Let's go into the treatments. What are the treatment options?
So until a couple years ago, the treatments could be pretty rough. The best thing that we kind of had to offer people was a combination of two drugs called pegylated interferon 1 and ribavirin. So the interferon had to be given as an injection once a week, and you had to take the ribavirin, a handful of pills, every day, and it could cause anemia, it could cause fatigue. Most people felt like they had a flu. You had the flu. You had to take it for a year, and it didn't work very well. So it was kind of hard to offer people that, say, here you can take these drugs that are expensive, they're going to make you feel terrible, and it's got about a 50-50 shot. Not many people wanted to take us up on that kind of deal. But in 2014, the initial sort of combination directly acting antivirals were approved. And those are specific drugs that inhibit the steps of the viral replication. So basically, these drugs keep the virus from making copies of itself. They are very directed at the virus, so they don't cause a whole lot of other side effects, which is new and different. And so now this chronic viral infection we can actually cure, and specifically in a shorter period of time. I mentioned the old drugs you had to take for a year. The new ones you can take. Most people, almost everybody can be treated somewhere between 2 and 4 months. Most people ended up getting treated for 3 months. You take the drugs for 3 months, and then we give people another 3 months for the drugs to wash out of their system and test to make sure the virus is really gone.
So you can totally cure the virus. It's not like you go into remission. You're actually cured of it?
Actually cured of it. So the virus is gone. The one thing that we tell people is, especially people who are treated at the later stages of infection, so we mentioned hepatitis C is a virus that causes damage over decades. Cumulatively, it can cause damage. And when you get to the time when you have scarring and damage accumulated within your liver, and that scarring we call fibrosis. So when you have a lot of fibrosis in your liver, that's what gives you the risk for liver cancer. So sometimes when people are cured later in the infection, they've already accumulated all this scarring in their liver, they still have a slightly higher risk of liver cancer than the general population, but it's reduced after the hepatitis C has been cured. So it's important to know the virus is gone, the infection's been cured, and they're not at risk to transmit it to anyone else, but they might still have some problems that need to be followed up and watched.
Is there a way, or do you recommend that people who have had hepatitis C either currently or previously, should they undergo regular screenings for liver cancer, or do those exist? What should they do?
So absolutely. People who have advanced fibrosis, so stage 3 or 4 fibrosis and scarring of the liver, we usually recommend, at least for now, these drugs are so new we don't know exactly how these people should be followed, because they are pretty new in 2014. So right now, the sort of more conservative approach is that people who are in that risk group should continue to be followed for liver cancer and checked twice annually. the way to do that, it's an ultrasound, a pretty simple, painless test, but people have to do it, and it's sometimes hard to do something twice a year like that. But we recommend that people undergo that screening until we have more information. And a lot of people are really looking right now to see when people are cured of this infection with these drugs. Does that risk remain high forever? Is the risk only high initially after the cure for a couple of years, and then they can sort of cut down on the frequency of the screenings? Everybody hopes that's the case, but we don't have that data yet.
How readily available are these drugs? I mean, can anyone come into the clinic to see you, and if they have Hep C, they are a candidate for these drugs, or how easily do they have access to them?
So access is definitely the issue. A lot of cost-effectiveness studies have really looked at the cost of a cure under the old therapies and the new therapies, and the cost per cure is actually lower for these new drugs, but they are such an improvement over the old drugs, and they are so new that they're still priced very high, and so access can become a little bit of an issue. A lot of insurance companies, Medicaids, will negotiate special prices and allow access, but for the most part, it really, you have to work with somebody to try to get access to the medications. You can come into the clinic, be evaluated. We can offer staging to sort of figure out. Medicaid will cover treatment if you're stage 2 or above. A lot of insurance companies have similar guidelines, and you really just need to be evaluated in the setting of your situation.
Do you know what the cost would be out of pocket if someone doesn't have insurance or they don't qualify for their insurance to cover it?
So the list price varies. You can find online, they really vary. So some of the combinations are somewhere in the $50,000 range for a typical 12-week course, ranging all the way up to, if you're combining combinations between 2 different drug companies, it can exceed $120,000 per course. So it really varies a lot. I think the cost is really a reflection of how much these drugs are an improvement over what we had before, but the cost is also very much a factor that restricts our ability to treat people. And so working with assistance programs, working with insurance companies, as I say, a lot of insurance companies negotiate prices in particular. So we have people in the clinic who can sort of help navigate that and help try to expand access as much as possible. Some of the drug companies even have assistance programs you can apply for, and we've worked with people on those.
Do all infectious disease physicians have access to these drugs, or is it important for a patient with hepatitis C to be seen at a university-based medical center and experts such as yourself with access to the research and the clinical trials, or is this readily available to any infectious disease physician?
So a lot of payers, in terms of insurance companies or Medicaids, will encourage or require patients be seen by somebody with training in the drug. So the drugs aren't complicated, but they do require sort of a familiarity with how they work and how you need to monitor people on them. So that's important. A lot of people have been doing research to look and see who can treat hepatitis C, and looking at mid-level providers, primary care providers, and specialists, and comparing those. Our group has done some of that work too, and found that once people are sort of trained in these drugs, almost anybody can treat, but you do need somebody who knows how to do it and knows how to help you access the drugs.
How common would you say that hepatitis C is in the Baltimore, Washington area in comparison to the rest of the country?
Absolutely. So the overall prevalence in the United States is just over between 1% and 2%, which is pretty much kind of what you see sort of on average throughout the country. Baltimore's rate is a little bit higher, and we know that that's, it's been reported that there are pockets of hepatitis C. Hepatitis C is more common in people who are co-infected with HIV because of some shared routes of transmission. So when you look at people who have HIV, about a third of people will also be co-infected with hepatitis C. When you look at people with other viral hepatitis like hepatitis B, you see slightly higher rates of infection, again because of shared rates of transmission. We mentioned sexual activity is a risk, and so men who have sex with men have a slightly higher rate. Overall, within the city, the rate is definitely higher than the national average. It's somewhere approaching between 5% and 6%, I think, were the most recent numbers from the Baltimore Health Department.
Compared to the national average of 1% to 2%.
Compared to the national average of 1% to 2%. So it's a crisis within Baltimore City.
So you would recommend that if you're living in Baltimore, if you were born here, growing up here, that you probably should get tested or screened more so than maybe other people in the country?
Well, it's definitely, it's not, I guess I wouldn't say it's not in the air. You're not at risk just because you live in the city, but it is something that I agree you should talk to your physician about and ask them, whether it's something that you should be screened for.
Okay, Great. We're going to take some questions from the audience, but first, introductions behind the camera. We have Angela Jackson and Sonia Hamlin from the Marketing Department at University of Maryland Medical Center Midtown Campus. A quick reminder to continue leaving your questions for Dr. Wilson in the comments section below and to like our video if you're watching. Sonia, do we have any questions?
Sure, we do. Why does it take years for hepatitis C symptoms to show?
That's a great question. I think we don't entirely know, but one of the things that we think sort of underlies that is it's sort of the area under the curve. It's the overall exposure to the higher levels of inflammation that come with the infection of the virus. The liver is a pretty amazing organ that it's very resilient. It can really persist in the face of a lot of insults. The liver's job is to clean our blood and handle a lot of the toxins that we take in, either eating or ingesting with medications and other things. The liver processes and metabolizes these toxins. And so the liver really has very, sort of a depth of resilience and sort of reserve. And so it isn't until you sustain damage over long periods of time caused by these higher level of inflammation that it starts to have any problems. And we don't notice those sort of early stages of liver damage because your liver can compensate. And then it's only when you kind of lose the ability to compensate for that damage and completely overcome it that we notice the symptoms of hepatitis C, which is why it's important people get screened even if they're not symptomatic.
Is it possible for it to be hereditary, or do you have a greater risk of contracting it if your parent or sibling has it as well?
Only through shared exposures, or again, there is a rate of maternal to child transmission probably right around the time of birth. So only in the way that you might have shared exposures, or if someone shares a razor with their parent or something like that. But,
okay.
No, there isn't. There are some genes that have been associated with an increased, not susceptibility to hepatitis C, but perhaps a response. So some people are probably about maybe 1 in 4, 1 in 5 are able to clear hepatitis C without treatment. So some people, if they are exposed to the virus, may be able to their immune system may be able to eradicate it on their own. And some of those genes are obviously passed down in families. So if you had a parent who was able to spontaneously clear hepatitis C, you might be able to do that a little more likely to do that. But for the most part, the majority, about 75–80% of those who are exposed to hepatitis C will develop chronic disease.
Is hepatitis C sort of like HPV, where you could be the carrier of it and infect someone else, but maybe you're not presenting with symptoms yourself?
Absolutely. Some people have hepatitis C and never sustain a lot of liver damage. So that probably plays more into genetics and who you are as a host. If you drink alcohol, if you have other risk factors for liver health. But so some people can absolutely be. We don't really call it asymptomatic carriers, but people who don't really progress in terms of hepatitis C disease, they're just infected with the virus.
Great. Let's take another question from the audience.
Sure. Our next question is, if you're cured of hepatitis C, can you be reinfected?
Yes, you absolutely can, and that's a good question too. It's one thing that we counsel all of our patients on. You've been infected with this virus, we've treated you, we've been able to eradicate, but it's important to protect the liver that you've worked so hard for because you can be reinfected. People, the immune response that people develop to hepatitis C is actually not often a protective one. So it's not like many other viruses where you can get vaccinated, like HPV you mentioned, or even hepatitis B. We now know exactly what constitutes a protective immune response. Hepatitis C, there isn't a vaccine. We don't know exactly what epitopes or antigens, what areas of the virus you could really target an immune response to in order to be protected from that infection. And when people are infected and then treated, the virus is gone because the drugs worked, but not because the immune system learned how to protect your body from that virus.
If you previously had Hep C, are you at greater risk of getting it again versus someone who hasn't had it before?
Not that we know of without the exposure. The exposure is really the important thing. So that's what we tell everyone who's treated. You've worked so hard to really be treated for your hepatitis C. Let's now protect your liver going forward.
Do we have any other questions?
One last question. Along the same lines, if you have been cured of hepatitis C, can you then donate blood?
So that's a good question. So right now, the screening that is done in the blood supply is for the antibody. So the antibody is the body's own response to hepatitis C. So even people who don't have active hepatitis C infection, either those who've treated or spontaneously resolved their infection, will continue to have positive or reactive antibody, just showing that their body has developed a response to that. Their body has seen that virus before. That's how we screen the blood in the blood supply to be most cautious in terms of protecting the blood supply. So anybody with that response, even if they've been treated or spontaneously cleared, couldn't give blood, just to minimize the risk to those receiving blood transfusions.
So every time you're tested, it'll show up that you have hepatitis C, even though it's not active?
That you had had hepatitis C, that you had at some point been exposed to hepatitis C, whether or not you have active infection. So when we screen people, we screen with that same test. We screen with the antibody test. So people who have had hepatitis C and been treated, it's important that they know that and know that their antibody test will always be positive, meaning they had previously been exposed to the virus, but they have to be checked further with sort of a follow-up confirmatory test to look for the virus itself to see if they still have active infection.
Okay, I think we have one more question from the audience.
If you have hepatitis C, are there any reasons why someone would not be eligible for the cure? Maybe they're too far along in their disease, or are there reasons why they wouldn't be able to take the cure?
So there are several different drugs approved. There are currently 4 different drug combinations, fixed dose combinations, so pills that contain more than one medication that would constitute an entire treatment regimen. So we have many options now. There are certain medication interactions, so there are certain medications like amiodarone or some anti-epileptic seizure medications that interact with these medications and would make them hard to take. But for the most part, there are enough options now. We can offer treatment to almost everyone. We have treatments that are fine if you're taking certain medications that interact with some of the other medications. We have drugs that are approved for people who have advanced or what we call decompensated liver disease, and there are options for those. We have options for people who have kidney disease and might not be able to clear some of the drugs as quickly, so we have options for many different groups of people. We have options that we can use along with HIV medications in people who have both HIV and hepatitis C. There are certain instances where we don't treat hepatitis C, and that's always a decision that people would or a conversation people would have with their doctors, and a decision people would make with their doctors. Sometimes if somebody is on a transplant list for a kidney or a liver, and they would accept a hepatitis C positive organ, then they might be able to get transplanted more quickly, and in which case we would treat them after they were transplanted. Some patients, these drugs are new. Some people have been a little skeptical and want to wait until there's more data, and we're always happy to talk with those patients and offer them whatever information we have and what the options are.
Would the treatment plan be differently for a minor than for an adult?
There is increasing data using some of these drugs in children, and for the most part they've been very safe and well tolerated, but that's still an area of active investigation.
Other than seeing an infectious disease specialist such as yourself for hepatitis C, who else would be included in the patient's treatment plan?
So often the provider who's prescribing the therapy, often either working with a case manager or a social worker, just help sort of support them through the therapy. These medications work very well, but you have to take them. And it's sometimes hard, especially if somebody had not been taking medications every day. A lot of people with hepatitis C are young and healthy and not, taking other blood pressure medications or other things they have to take every day. So it can be hard to take that. We have been able to work with case management and other people to kind of support them, give them an opportunity to call if they're having any side effects or if they have any concerns, if they lose medication, to try to figure out how to help them complete the course and have the best chance of cure.
Once someone has been diagnosed with it, how often should they see their provider for follow-up medical care?
So that's an individual assessment. So some patients need to be seen a little more frequently. These medications are all different, and some of them need to be monitored a little more frequently. Sometimes people need to come in for lab work as frequently as every 2 weeks. Some people absolutely only need to be seen every month or less because they're not at risk for other side effects. It really would be part of an individual treatment plan, but again, talking with the physician about what works for you and what works with your life in order to to have the best chance of curing this infection is what we do with everybody.
What would you say the biggest misconception is about hepatitis C or people with hepatitis C?
I think there's a huge stigma, and it's as with many stigmas, incorrect. So many people think, oh, well, that's just a disease of injection drug users. That doesn't affect me. It affects almost all of us, and if you almost all of us would know somebody who has been affected by this disease. It's associated with blood transfusion, it's associated with sex, it's associated with razors and other medical practices that involve blood. People who have had needle sticks, a lot of healthcare workers have been at risk for this. So it's just something that we need to normalize, we need to talk about, because there is a cure and it improves outcomes. It reduces rates of liver cancer, it reduces need for liver transplantation and other extrahepatic manifestations, we call them, kidney failure, cryoglobulinemia, vasculitis, lymphomas. Other things can be associated with this, and we can prevent all of that by treating people. So.
For those who are watching and still have questions about hepatitis C or have any interest in seeing you or one of your colleagues for a consultation, what do you suggest next?
I think calling and having an appointment or talking with your primary care doctor about whether they can refer you, I think is a good first step. And we talk to people about these drugs all the time. We've helped people in all different stages of this process try to get there, and we're getting pretty good at it.
And how can they reach you?
I think we have the phone number here, right? Do we have the?
Sure, 410-225-8369. You can reach Dr. Wilson to schedule a consultation or any of our other infectious disease specialists at the University of Maryland Medical Center Midtown Campus. So that's all the time we have today, but you can continue leaving your questions for Dr. Wilson in the comments section, and we'll get back to you in 48 hours. Thanks.
Thank you.